Hello there. Welcome to this demo of a renal intervention on the Mentice VIST G5 endovascular simulator. My name is Tim Lawler and I'm a simulation technician with RCSI. I'm not a clinician, nor have I any affiliation with Mentice, so please excuse any bad practice and or misinformation that I may share with you in this video. So this is what you will see once you log into the software. There are 8 different modules available on this particular laptop, shown here on the left. Today we are doing a renal intervention, so I'm going to click on it and a list of cases will appear on the right. These cases are displayed in order of difficulty, so the first case is usually straightforward with a normal anatomy. The more difficult cases will involve lesions that are more challenging to manage. There is a step-by-step guide for one case in every module. These guides lay out clearly all the steps to take in the procedure, including which specific devices to use. This allows someone such as myself, who has no clinical experience and minimal knowledge of the devices used in endovascular surgery, to complete a procedure appropriately. For renal intervention, there is a step-by-step guide for the first case, patient R13. So I'm going to jump straight in. So now I'm going to go through the most important tabs on the laptop interface that appear once you begin a case. The Scenario tab presents you with all the relevant patient data, such as demographics, lab results, past medical history, and also X-ray or CT imaging if available. It's a good idea to read through all of this information before beginning the operation. We'll take a quick look at the imaging for this case, and we see that the patient has had an angiogram done of their right renal artery, clearly showing the stenosis at the proximal third of their artery. We also have the patient's baseline vitals and some discussion questions. The Controls tab is basically a digital version of the control box with a few extra features, such as changing the fluoro pulse rate and switching DSA on and off. Just like with the control box, we can move the operating table and C-arm, collimate magnify, and capture images and place roadmaps. The Injector tab allows us to inject with precision by setting the volume and rate. The Series tab contains recorded cines from the fluoro screen. Images on this tab can be used as masks for a roadmap. The Series tab is empty right now, as we haven't recorded any cine yet. The Medication tab can be used to administer various drugs. Depending on the drug, this can be a bolus or infusion or both. You can also choose the route of administration. The tab that we will use most frequently is the Inventory tab. This is where we choose our puncture site and choose which devices we are going to use before inserting them into the haptic machine. For this case, we only have one option for puncture, which is the right femoral artery. So I'm just going to go ahead and click Get Device. As you can see, there is a wide range of different types of device to select here. This screen gives you all the potential devices that can be used for this case. For different modules, this screen will have different options, such as microcatheters for a TACE case. So going by the step-by-step guide, the first tools I will need are an 035 J-curve guide wire and a 5 French pigtail catheter to perform an angiogram of the renal arteries. As you can see here, there are a wide range of 035 guide wires with different lengths and tips. I'm going to go ahead and select a 150cm J-tip guide wire. I'm now going to click Get Device again and find my 5 French pigtail. This is a flush catheter used for running contrast when performing angiograms. It is important to note that we don't need to put the real life device into the machine. It just has to be roughly the same diameter and have a straight tip. So we have both our devices and are ready to insert them into the machine. You will notice that these devices have one or more buttons beneath them. The syringe is for selecting which device you are injecting through when multiple catheters are present, and the auto track button allows you to follow a device tip on the fluoro screen. I'm going to go ahead and follow my guide wire. So this is our fluoro screen. As you can see, we have fluoroscopy of the patient, a graphic of the C-arm and operating table position, and the patient's vitals. We can see our selected devices up in the top left. They are greyed out at the moment, as we have not yet inserted them into the machine. These will illuminate once the simulator recognises tools being inserted, as you will see now. Now this is a bit of bad practice here, because I believe I should be following my tools with fluoro once they've entered through the introducer sheath in the femoral artery. Here, I've hit the X-ray pedal and found my devices are in the abdominal aorta. I should also note that the introducer sheath is automatically in place once you select your puncture site. The guide is instructing me to position the pigtail at lumbar vertebrae 1, which is just above the renal arteries. I do not know where this vertebrae is, so it's going to involve some trial and error. So I've taken a guess here, and I'm going to run contrast from this position. I remove my wire until it goes grey on the screen. It is technically out of the patient now, even though it still rests partly in the simulator. Using the physical syringe connected to the simulator, I find that I am just below the renal arteries. I bring my pigtail up to L1 and run contrast, giving me a nice picture of the renal arteries and clearly showing the lesion on the right renal artery. I also record a DSA here, which is done by pressing the cine pedal and injecting contrast. The next step is to bring my guide wire back up and remove the pigtail catheter from the patient. Once we have removed the pigtail, we can advance our 7 French guiding catheter that we will use to cannulate the renal artery. I've selected a 7 French renal double curve adult. I advance my guiding catheter close to the renal arteries and inject contrast to check my position. In real life practice, the guide wire is always removed before injecting, but the simulator allows you to inject with the wire in situ. When cannulating a vessel, we pull back the wire to allow the tip of the catheter to take shape. From here, we can easily manipulate it with our hands. The tip of this catheter is purpose built for cannulating the renal artery, so even I succeed without much hassle. The next step is to insert a 5 French diagnostic catheter and advance it over the guide wire. I've chosen a Cobra 1 selective catheter. The purpose of this catheter is to gain access to the ostium of the renal artery. The Cobra is now at the ostium of the renal artery. The next step is to retract the guiding catheter to the third lumbar vertebrae to allow the tip of the Cobra to take its shape. I inject some contrast here to confirm my position. The next step is to remove my 035 J-curve guide wire from the patient. I am then going to select and insert an 018 guide wire. This microwire is used for navigating narrow vessels. Here, I will pass it through the stenosis and place the tip into one of the branches of the renal artery. You will notice here, when I hit the X-ray pedal for fluoroscopy, that I've lost my position in the ostium of the renal artery. Again, I failed to use fluoroscopy when removing and inserting tools, but I do have an excuse. Just like in real life, these procedures are generally done with an assistant who aids with the manipulation of tools. Today, I'm operating alone, and it's very difficult to be in 2 places at once. With 3 tools in the simulator, removing the guide wire requires the 2 catheters to be fixed in place, which is where your assistant comes in handy. Without an assistant to help me fix the tools in place, I lost my position with the Cobra when removing the guide wire. I've managed to borrow an assistant here to help me regain my position. This allows me to manipulate both of my catheters and also use the X-ray pedal while he fixes the guide wire to the table. So I've managed to position my Cobra catheter into the ostium again. I will now pass the 018 guide wire through the lesion and place the tip distally into a branch of the renal artery. What I should be doing is using the Cobra as a rail to position my guide catheter in the ostium of the renal artery and then removing the Cobra. However, I appear to be having a spot of trouble doing this cleanly due to being a novice and also due to my assistant abandoning me. So I'll fast forward through this mess until I'm in my desired position. So now that I'm happy with my guide wire and guiding catheter position, I can now begin to treat the stenosis. I'm first going to pre-dilate the vessel using a dilation catheter. This will expand the vessel to its native diameter, which will allow for optimal stent sizing. A real-life dilation catheter can be used in the machine for this, but I'm going to use the same 5 French catheter that I used as my Cobra, which will behave no differently in the simulation. So as you can see now, I've brought my dilation catheter up along my guide wire and out through the guiding catheter. The 2 radio-opaque dots indicate either end of the inflatable balloon of the dilation catheter. Using these dots to guide me, I position the dilation catheter in the lumen of the lesion. I then retract my guide catheter just outside of the renal artery ostium to prepare for dilation. To inflate the balloon, we use a physical inflator device very similar to its real-life counterpart. It is filled with water before use and connected to the haptic machine. To inflate, we turn the handle clockwise until we reach our desired pressure. I believe that on some real-life inflators, a pumping motion can be used with the handle. This is not the case with this device, and doing so may damage it. We simply turn clockwise to increase pressure and anti-clockwise to decrease pressure. Watch the dilation catheter now as I inflate it to an appropriate pressure. I will leave it inflated for 30 seconds. I will now deflate the catheter and remove it from the renal artery so I can position my guide catheter in the ostium for injecting contrast. Again, proper practice would be to completely remove the dilation catheter before doing this, but as the simulator allows me to leave it in the guide catheter while injecting contrast, I leave it close by in case my pre-dilation angioplasty wasn't successful. I bring the tip of my guiding catheter to the renal artery ostium and perform an angiogram. As you can see, the vessel has been expanded successfully with the dilation catheter. Now that the renal artery is ready for stenting, I'm going to talk a little about the measurement tool in the simulator. This tool is found in the Series tab when you select one of the images that you have recorded with the Cine pedal. To take a measurement, you must first use something in the image that you know the dimensions of as a reference, such as the diameter of a catheter. So you click the References button, input the correct unit and dimension, and then take the reference measurement on the image. Now that your reference is taken, you can click the Measurement button and then take your desired measurement on the same image, for example, the renal artery. You may have noticed me messing around with the reference measurement tool on the image as I explain it to you. However, I do not actively use it to size my stent, as the step-by-step guide conveniently told me which size stent to select. I eventually remove my dilation catheter and select the stent that I will be using. The stent I've selected is a 4x15mm balloon expandable stent. This means it is deployed in the artery just like how we pre-dilated, by inflating a balloon. Like with the dilation catheter, I advance my stent up to the proximal renal artery, perhaps a little hastily. Once again, I'm using the same physical 5 French catheter in the machine that I used for my previous tools. I position the stent using the radiopaque dots as my guide, and retract the guiding catheter to just outside of the renal artery ostium. I inflate the balloon just like before. You may notice that it looks thicker than the dilation catheter did, as it has a 4mm diameter as opposed to 3. As I deflate the balloon, you'll be able to see that the stent has been deployed in the proximal renal artery. We'll perform an angiogram to check if it has been expanded sufficiently and is in the correct position. I remove the stent catheter and bring my guiding catheter up to the renal artery ostium. From here, I inject contrast to see the flow through the stent. Now, I am no doctor, but I think I've done a pretty good job implanting this stent in the right renal artery, judging by this angiogram. We can choose to post-dilate with another dilation catheter or balloon if we wish. However, I feel that the stent has been implanted sufficiently along the walls of the artery, and I'm happy to leave it as is. So we've finished treating this renal artery stenosis with angioplasty and stenting. To finish off the procedure, I will insert another pigtail catheter to perform a final angiogram of the renal arteries. I take a bizarre approach to this, leaving my guide catheter in place and using the 018 guide wire as a rail to advance the pigtail. After more messing around, I position my pigtail at L1 and make a final angiogram. When you see it, I think you'll agree with me that this man's right renal artery looks a lot healthier now than it did in the initial angiogram. As I struggle with my tools here, I'll take this opportunity to tell you the physical tools I used in the simulator for this procedure. I used an 035 guide wire and an 018 guide wire for my wires. I used the same 5 French catheter for the pigtail, cobra, dilation and stent catheters, and I used an 8 French catheter for the guiding catheter. You can really use any real-life device in the machine so long as it has a straight tip, so you can simply clip off any curved tips and use them in the machine. So I'm finally getting to where I want to be with my pigtail, and I run a few final angiograms to complete the procedure. I should remove my devices from the patient before I exit the case, but of course I failed to do this. So this was my first attempt at the renal intervention on the Mentice FIS G5, which is evident by the amount of mistakes I made. Nevertheless, I hope you enjoyed this video and learned something from it, and I look forward to making many more in the future. I'm going to finish up by chatting briefly about the reports feature. A report will appear once you exit the case and will provide you with an extensive range of metrics that were recorded as you performed the case. This will include general statistics such as milliliters of contrast used and time under fluoroscopy, but also case-specific metrics. You can see the metrics specific to the renal angioplasty I performed here, relating to my treatment of the lesion, with a section for predilation metrics and a section of metrics for the stent. There is also a handling event section, which tracks the number of times that you make certain handling errors. As you can see here, there were 3 occasions where my diagnostic catheter was too deep into the ostium. There is also a complete timeline of the case, which logs every action performed throughout the entire procedure, with significant events highlighted in bold. Benchmarks can be set for learners, where minimum values can be set for all of the metrics. When the learner finishes the case, the report will show a pass or a fail for each of the metrics. This is a screen grab of a timeline of all the EVAR cases performed using the guest account, showing the benchmarks for total time and contrast used and where the operator ranked in each case. Benchmarks for every module can be imported from an Excel file and can be specific to each user account, i.e. more challenging benchmarks can be set for more senior trainees. These reports can also be exported to Excel using an admin account. So that's the end of this demo. I hope you enjoyed it and learned a thing or two. Thank you very much.